Hello, everyone. My name is Claudio Ronco. I'm professor at the University of Padua and chair of the Department of Nephrology and International Renal Research Institute in Vicenza, Italy. I've been asked to cover the topic of COVID-19 associated AKI in terms of mechanisms and possible potential management. Best regards from our university, which is going towards 800 years of history, and my disclosures that did not affect the speech that I'm presenting here is that I am in the advisory board of almost every company involved in extracorporeal treatments. We know that after SARS in 2004 and MERS, SARS-CoV-2 was first reported by officials in Wuhan City, China in December, and the virus was identified in early January and its genetic sequence shared publicly on January 12. Curiously enough, already on February 6, we published in Lancet Respiratory Medicine the concept that we should prepare for extracorporeal organ support in intensive care because it is not possible to anticipate the extent of the epidemic and consequent number of patients requiring intensive care management. And in fact, a tsunami in the ICU came, and once we have learned the syndromes involved in COVID-19 infection, we learned that people can be totally asymptomatic, can present mild symptoms, or they can end up with moderate to severe symptoms, including a severe respiratory dysfunction. Radiological findings have become quite familiar with people dealing with these patients in condition of non-severe and severe syndromes, and in particular, severe manifestation of COVID-19 are depicted by several different areas of involvement of the pulmonary tissue. Now, we published quite early also about acute kidney injury in SARS-CoV-2 infected patient, summarizing the fact that AKI is frequently observed in ARDS patient affected, especially by different comorbidities. And ARDS associated AKI may be ascribed to several different causes, and we will explicate very quickly the inflammatory immunoreaction that characterize the enhanced release of circulating mediators damaging the kidney. Kidney epithelial cell viral infection may worsen local inflammatory response, and in fact, this may have an effect on duration of AKI episodes. Finally, comorbidities may be associated with pre-existing chronic decline of kidney function and patients with reduced renal functional reserve and with the tendency to develop AKI episodes are among these patients. Identification of patients at risk for AKI with biomarkers may lead to a better allocation of resources. And finally, the use of extracorporeal blood purification technique and antiviral therapies may theoretically limit the systemic and local inflammatory response, at least. We have discovered the viral particles in the kidney tissue, and so we published in Lancet the mechanism by which our patient can be presenting severe kidney dysfunction. One is a condition of direct endothelial damage, podocyte localization, proximal tubular localization, mitochondrial dysfunction, and acute tubular necrosis. The other is through hypovolemia or by the filtration through the glomerulus of damage-associated molecular patterns that derive from the wide and important release of cytokines in the syndrome. This may cause endothelial dysfunction and finally acute kidney injury. Pneumonia itself through an ARDS, or the additional effect of mechanical ventilation or even ECMO may aggravate kidney function, which in turn may lead to fluid overload and hypervolemia, worsening the level of pulmonary exchange dysfunction. Finally, there is a hypercoagulable syndrome that may cause endothelial damage, may induce rhabdomyolysis, kidney infarction, presence of microthrombi that, combined with myocardial dysfunction, arterial underfilling, and venous congestion, may further aggravate acute kidney injury. There is therefore what we call an important organ crosstalk that has been published to be part of the SARS-CoV-2 severe syndrome. Now, cytokine storm has been considered one of the most important aspects related to the defect and altered immune system response of the host. Early lung involvement with cough, fever, high ferritin, CRP, LDH, and interleukins may all be indication of an impending cytokine storm. Acute phase reactants, specifically ferritin as LDH, are readily available tests that may allow early recognition. And finally, early treatment with anti-IL-6 drugs or antiviral drugs may prevent severe complication and death in some patients with cytokine storm. Do we have other options? Well, yes, we do. In fact, if we consider the cascade infection, immune response, and organ damage, we may consider viremia as a target, cytokines as a target, or organ failure as a target for virus removal, mediators removal, organ support. Now, the theory is that, in fact, there is a complete dysfunction of the immune system that may lead to pro-inflammatory and anti-inflammatory mediators response, leading to endothelial dysfunction and organ failure. This induced us to publish the potential for extracorporeal therapies in removing cytokines and therefore preventing the CRS-induced organ damage. By inducing a modulation in the secretion and concentration of circulating cytokines and cytokines in tissues by hemoperfusion of CRT, we may actually cause endothelial protection and also prevention of organ damage, as described in this slide. Because many of these inflammatory molecules are in the range above 20,000 Daltons, we know that standard dialysis cannot probably be accurate enough in removing these substances. So we have different options based on the pathophysiological rationale, which are medium cutoff membranes, where you see clearly that there is a higher range of molecular weights removed by this new type of membranes, or by adsorbing membranes, in the case of auxiliaries, where large amount of mediators can be removed by adsorption on the surface of this molecule. And finally, by sorbents itself, like the cytosorb or like the HA380 from Jaffron. This is the case of a patient from admission to day 3, where he developed hemodynamic instability. He was treated for 3 days with hemoperfusion, and finally was stabilized and extubated on day 12. We published in Lancet Respiratory Medicine about management of acute kidney injury in patients with COVID-19, suggesting the potential use of extracorporeal therapies. And here is about indication, preparation, prescription, delivery, and monitoring of different therapies. I invite you to read this paper, which somehow suggests different steps for use of medium cutoff membrane, for adsorption, and even for extracorporeal organ support with extracorporeal CO2 removal and maybe ECMO. One of the important things is the use of anticoagulation in this patient who present high level of hypercoagulability, and therefore we should also avoid high filtration fraction and possibly change filters as frequently as possible. Now, in the end of all this rapid pathophysiological rationale for mechanism and the use of extracorporeal therapies, we have published also some research questions that need to be addressed. And therefore, we need to establish the value of tubular damage biomarkers and the potential to guide optimal fluid management, ventilation strategy, and recruitment maneuver. Clinical trials should investigate early initiation of renal replacement therapy and sequential extracorporeal therapies, including endotoxin removal, cytokine removal, and organ support, especially in those patients who have a superimposed sepsis syndrome. Trials are needed to clarify the role of hemoadsorption and other extracorporeal systems for cytokine removal in patients with cytokine storm, and studies should aim to clarify the safety and feasibility of low-flow extracorporeal carbon dioxide removal in these patients. Finally, we should establish the proportion of patients with a superimposed bacterial sepsis that may need the use of sequential extracorporeal therapies. Part of these questions have also been analyzed by a recent ADCI meeting, which is a consensus conference we have held recently virtually, and the paper should be published very soon in Nature Reviews Nephrology. With this, I would like to leave you with the last message, which is our Vicenza course on AKI and CRRT that will take place on November 3 to November 5, not in Vicenza this year, but virtually on the web. And many of the important speakers participating in ISICEM are also part of the faculty of this meeting. We will also have a special section concerning our use of CRT and extracorporeal therapies based on the pathophysiological mechanism of AKI in COVID-19 patients. With this, I thank you very much for your attention.